So thanks very much for asking me to speak today to the team. It's there. So I'm a GI surgeon in Doncaster. I'm the college tutor there and also a member of the Trainer Education Development Working Group for the IST project. And I've been asked to talk a little bit about how we use the ANPs in Doncaster. But I'm guessing some people probably don't know where Doncaster is, so I'm down from God's own county today. And we're situated in the southeast corner there. We've got a patch that actually covers a bit of North Nottinghamshire and sort of north-west Lincolnshire. Population, catchment area, somewhere around 500,000. So we're a large DGH. We've got about 12 GI surgeons, we've got vascular surgeons, urology and breast surgeons, plenty of them. And the team that we're going to talk about today covers all of those sort of general surgical areas. But you don't really want to hear from me because I can't really take credit from any of this. So what I'm going to do is let the people talk for themselves. We'll hear from Deanna, who's our lead surgical nurse practitioner, who's far too busy and important to be allowed to leave Doncaster, so unfortunately can't be here today. And we'll also hear the trainee perspective on how it's like and what it's like working with the ANPs. Deanna, thanks very much for talking to us today. Perhaps you could start by giving us the background to your team.
Okay, so the role of the nurse practitioner at Doncaster started in 2004 as a direct result of the European Working Time Directive and the reduction in junior doctors' hours. At that time we started with 4 nurse practitioners and we learnt our job on the job. We followed the junior doctors around, did ad hoc courses, but our aim at that time was to streamline the patient's journey and ensure they had rapid access to emergency surgical opinion. If we fast forward 13 years to today, we now have 5 advanced nurse practitioners, 1 trainee advanced nurse practitioner, 5 surgical nurse practitioners and 4 clinical support workers in our team.
Fantastic. So for us, what's the difference between a surgical nurse practitioner and an advanced nurse practitioner?
So the main difference is that the advanced nurse practitioner is educated to master's level and during their training, which should last 2 years after they've been trained as a nurse for 5 years, they will complete a competency-based assessment, similar to what the junior doctors do now, in that they're going to be doing DOPS and mini-CECs and CBDs. The surgical nurse practitioners, although they are educated to master's level, they aren't completing the competency-based assessment. So therefore, the advanced nurse practitioner will work autonomously once they're qualified, whereas the surgical nurse practitioners will work under supervision, usually with the FY1 team.
Okay. So tell us about how the advanced nurse practitioners are working within the acute surgical service across our sites.
So at the Doncaster site, we have an ambulatory care unit. It is a appointment-based system working Monday to Friday at 8 AM till 9:30 PM. We have 2 advanced nurse practitioners working autonomously seeing patients and we have 27 appointment slots in that time and we get referrals from ED, GPs and patients themselves will refer themselves to us as well. And we see breast, vascular, urology and general surgery patients. At the Bassetlaw site, it's taken one step further because there aren't any junior doctors at Bassetlaw. So the nurse practitioners will take any referrals from ED and actually go down to the department to see patients. And they'll also take ward referrals and go to the wards and see patients, as well as running a hot clinic and seeing GP patients there. They have got a consultant on site working 8 till 6 Monday to Friday, so they're there for support if you need any senior input.
Okay, so those roles have really developed over the years. How do you think that all these roles impact upon training for junior doctors?
I think they've had a massive impact on the training because the advanced nurse practitioners are taking away the ambulatory patients from the core trainees. Whereas before the core trainees would be expected to see and clerk any of the referrals, they now have time to spend with the sicker patients that are referred from ED. They are still the first protocol from ED with the sick patients, so they still have to see those patients, but they've got more time to spend with them. They've also got time to go down to emergency theatre when they're on an on-call block. Similarly, on the ward area where the surgical nurse practitioners are working, they're ensuring the smooth running of the ward, so the core trainees have not got to be there all the time supporting the FY1 doctors.
Yeah, absolutely. What sort of problems or issues have you come across during your 13 years?
The main problems would be that some specialities don't want to take referrals from nurses or advanced nurse practitioners, although that does seem to be decreasing. The other problem we have is that we'll train up nurse practitioners to master's level, and then they defect to the community because they pay at a higher band than the hospitals do, and they're doing similar work but in the GP surgeries there.
And anything about the future for the team?
In the future, we want to increase our team and be incorporated on the on-call rota and the junior rota. At the moment, we're looking at putting an advanced nurse practitioner into one FY1 slot, but that will increase in the future. The other thing that we're looking at is the clinical support workers, which I haven't talked about very much, a valuable members of our team, and we're looking at putting them on nights to support the doctors because they can do the vena puncture, cannulation, ECGs and catheterisations, and taking those tasks away from the doctors so they can concentrate on the sick patients at night.
Great. Thanks for your time, dear.
Okay.
Hi Emma.
Hello.
Thanks for coming. I'd be really grateful if you could give us the trainee perspective on our use of surgical nurse practitioners and advanced nurse practitioners in Doncaster.
Okay, so I'm an ST7. I've been in Doncaster for about a year doing general surgery, and I'm now doing breast here. So I've been working with nurse practitioners in 3 roles, so I thought I'd talk about those separately. First one is on the wards, second one is in the surgical assessment unit, and finally in theatres, although technically I think those are first assistants. And then I'll talk a bit about my views and then also some of the opinions I've collected from my colleagues. So on the wards, the nurse practitioners arrive before us. Usually they're at about 7 and attend the nursing handover, which is really helpful. They then come on the ward round, prepare the patient list, and they're an extra pair of hands. They mean that we've got an extra body to do things like take the computer along with us, look at results and access the pharmacy online programme. Which frees up the F1 so that they can actually listen to what's going on, have a look at the observations and document, and not try and do a million things at the same time. So that's really helpful, and it makes the ward rounds run just that bit smoother. They then stay on the wards and help the F1 with jobs during the day. So they sort of divvy things up. They'll do some of the TTOs and mean the F1 is free to do the interdepartmental referrals and see patients. And they then chase all the results during the day and document everything. So in surgical assessment unit, the nurse practitioners see the new referrals both from GP and increasingly from A&E. They clerk them, they do the initial bloods and investigations, and then they'll contact one of the middle grades once they've got that information, or sooner if they're worried about the patient, so that we can make a decision about whether the patient needs to be admitted, whether they need an operation, and that process runs very smoothly. And it also potentially frees up the core trainees so that they're not spending all their time in A&E seeing new referrals. In theatre, the surgical first assistants are a really good sort of learning resource, I suppose, particularly for more senior trainees who are starting to operate independently where they don't need a consultant scrubbed with them. So the consultant can go and stand in the corner and watch, or even be in the coffee room and allow the trainees to gain a bit of confidence. They've also obviously seen and assisted in hundreds if not thousands of operations, so they're a really good resource for telling you whether they are happy or not happy with what you're doing. So those are the places that we've worked together. My observation is that they provide continuity, so they are there all the time, and they know the system, they know the hospital, they know the consultants, they know what they like and don't like, and they know surgical patients as well. They've often worked with them for years and years and provide a really good resource for the juniors and continuity. So the only disadvantages I've spotted are that they aren't always there Monday to Friday in the same way that an F1 might be, so they don't always know the patients. And what else have I written down? Yes, just occasionally, I think towards the end of the F1 year, when F1s maybe would be stepping up a little bit, they perhaps provide more support than the F1s need. But generally I'm very much in favour of having nurse practitioners. I think they're a really valuable addition to the team. In terms of what my colleagues have said, the registrars have said they're extremely useful. And they've noticed when they come up from theatre at the end of the day, there isn't usually a great big long list of jobs to be done still. A lot of things have already happened, and that's quite different to other places that we've worked without nurse practitioners. They bridge the gap between doctors and nurses, so I think they improve communication both ways. And the extra person to help with ward rounds makes things just run that bit smoother. The core trainee that I spoke to said that they found that August was a lot smoother for everyone, and that the extra pair of hands to update the list and chase bloods was really appreciated. But the main thing that they noticed was that the fact that there was adequate ward cover meant they didn't feel obliged to stay on the ward and help, that they could go to their theatre sessions and clinics without worrying about what was happening on the ward, which is really good, obviously. The F1s have mentioned that it was really helpful having someone who knows the ward and the consultants, and that they would have really struggled in the first few weeks without them in a busy job. And they also noticed that it just provides a lot of continuity. So I think that's the main thing that seems to be consistent. So those are my main observations.
That's great. Thanks for your time, Emma.
Okay.
Okay, so I'm not here to take credit for any of that because very little of it is to do with me. And I'm not pretending that Doncaster is unique, but I'd be happy to take any questions from you about how we do things or have done things in Doncaster when we have our session in a moment. And we can also talk perhaps a bit more about how we're planning to put them onto the on-call rotas to support the teams and in particular core trainees and the IST. Thanks very much.